On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Sherrie Ballantine-Talmadge. Dr. Ballantine-Talmadge is board certified in both family medicine and sports medicine. She enjoys utilizing her broad spectrum of training to care for active individuals and athletes as a primary care sports medicine physician. She completed her sports medicine fellowship in Toledo, Ohio. Her unique combination of osteopathic and sports training allows her to approach patients in a comprehensive manner, from the recreational to the Olympic level athlete. She has worked at 3 Division I universities, served as team physician at Northwestern University, and travels as a team physician with U.S. figure skating. She has also provided coverage at the Chicago Marathon and at the Kona Ironman Triathlon. Dr. Ballantine-Talmadge sees patients at CU Sports Medicine and Performance Center in Boulder. Welcome to Dr. Ballantine-Talmadge.
Thank you so much. I'm really excited to be here. It's an appropriate time to be here because I think for most of you, our kids have been in school for about a week. And what a perfect time to talk about concussions. And sure enough, right away, we saw our first concussions from the school year. The first week, kids were back in school. So what a great time to do this. I'm so appreciative of BCH allowing me to come and talk with you tonight about concussion. So how do we figure all this out? Well, lucky for me, around the time that has been my training, there was this thing where we had lots of different grading scales, and it was very confusing how you did concussion. And then in 2001, there was the first international consensus statement that came out. And in subsequent years, as you can see, this has been completely updated. And more recently, we got the 6th international statement on concussion and sport-related concussion. And that came out in 2022. You can see there's a little bit of a lag because of the fact there was this thing called COVID. But the context of my talk tonight is really based on what is in this guideline that we use really internationally from the Olympic level. All over the world, we use these guidelines. So this most recent paper was really helpful because we were looking for what's the latest and greatest in concussion. So if you're ever interested, I know you have the copy of these slides. The reference of that journal article is here for you on the slide. And the article itself is built into 11 R's of sport-related concussion. So to be very clear, I want to make sure that we're all talking the same language. When we talk about concussion tonight, we're talking about sport-related concussion, so SRC. This is going to be different than a motor vehicle accident concussion. This is going to be different than a military blast concussion. Those other kinds of concussions are very different, and they have different things that we have to think about, and they typically take a lot longer to get better from. So in the context of sport-related concussion, this is a really busy slide, but how do we define concussion? That's extremely important, and you can't imagine how much time goes into people talking about how you define this. So it's technically a traumatic brain injury, as you can see. It's caused by a direct blow to the head, the neck, or the body that results in an impulsive force that then causes transmission to the brain. And so what you should take from that is that, yes, you hit your head. Yes, you can hit your neck. You can hit another place in your body and get a concussion. What happens is it causes this massive neurotransmitter and metabolic cascade that changes the way your brain functions. So there's not something that we can necessarily see on an imaging like a CT scan or an MRI. It's a functional disturbance. And then the symptoms either happen immediately or they can evolve. When you think in my career of how many thousands of concussions I've seen in my career, sometimes I don't even know in those first minutes when I'm standing on the sideline. So they can evolve over time. And again, like it says here, there's no abnormal findings on traditional imaging. There are experimental things that we can use, but nothing that we're able to use in clinical practice yet. And this is really important. It may or may not involve loss of consciousness. You know, back in the day, we used to grade concussion. Did you lose consciousness or not? When 2001 first came out, it was simple or complex based on like loss of consciousness. And it's just easier, did you get a concussion or not? And then this one, which becomes pretty relevant sometimes when you work on a college campus, is that the signs and symptoms can't be explained by being on drugs or being on alcohol or medication or misuse or other injuries. And we'll come back to that. So that's the definition, and that's what we're talking about tonight. I think one of my favorite things that come out of that most recent international consensus guideline is this statement here. And I always tell when I teach, if you get one thing out of my lecture tonight that changes the way that you think or the way that you do things, then it's a victory, right? So what's the one thing that you can learn? And maybe this would be one I would say. So with all the changes that happen, and as we constantly look at concussion, we have a saying in concussion that once you've seen one concussion, you've seen one concussion. And so here it says in the statement that with all of these changes, we still need to remember that assessment, treatment, management, and advice is still specific to each patient. And even if a patient receives multiple concussions, that concussion that they had 2 years ago might look completely different than what they had recently. So this is important because it talks about how it has to be individualized. So for you tonight, as the person that is trying to sort through this, where is the truth? And just like any bell-shaped curve, you find that the truth is usually in pretty short supply. So I hope tonight that that's what we can establish. So really quick, we always do this because it's so good. Make sure that we're all speaking the same language. So myths and facts, you have to hit your head. Okay, if we had like a poll in the audience, this is where we would say, like, is this true or false? So you have to hit your head. Is that true or false? Okay, you need a CT scan or an MRI to diagnose a concussion. Okay, well, you do not have to hit your head, right? Because you can get a whiplash mechanism of injury. We see that. I've even had people hit and fall on their bottom, get a sacral injury, and it transmit all the way up into their head and get a concussion that way. So you don't have to hit your head, right? You need a CT scan or an MRI to diagnose concussion? No, you don't. If you are getting a CT scan and the MRI, it's because those wonderful people in the urgent care or the ER are making sure you haven't broken your skull, you don't have a brain bleed, okay? But all these other tests that we have, they're completely structurally normal when you have an MRI. If you lose consciousness, you're in big trouble. Is that true? No, we just learned that the majority of concussions actually happen without loss of consciousness. And actually what's really interesting, we'll talk about this a little bit later, loss of consciousness does not dictate concussion severity, actually. What about this one? This one's a pretty common one. Helmets and soccer bands, you know, those things that you wear around your head for soccer, that they're going to prevent concussion. In as much as I'd love to tell you that there is a helmet that's going to prevent you from concussion, if that was the case, then football players and ice hockey players would not get concussion, but we know that they do. So those things are there, as well as mouth guards that we'll talk about too, to make sure that you don't die from a head or a skull fracture or a brain bleed, right? Okay, what else? So this one drives me nuts. I don't know where this comes from, but we see this a lot, and it adds to people, kids and adults, having delayed recovery from their concussion. Once you have a headache and it is gone, you can go back to play. This is absolutely not true because there are so many other symptoms that are related to concussion that if you tell someone that just based on their headache they can go back, you're missing something really big. And in fact, dizziness can also be something that really adds to prolonged concussion. So if your main symptom is dizziness and you don't have a headache and you go back and you still have dizziness, you're still basically returning someone to their activity still concussed. Okay, this one we get calls from all over the country about this. Our patients will travel and go to different races and things. There's nothing you can do for a concussion. This is outdated, guys. So concussion there's an active approach. And what I mean by that, gone are the days of sitting in a dark room and doing nothing. There's always something that we're doing for concussion. The reason that this is important is if you think about the patient population that we're dealing with and about how activity is a huge part of who we are, when you take someone and you give them a concussion and you tell them that they can't do anything, it's going to cause them eventually to get anxiety and to get depressed. So in concussion and thinking of it as active management, it can really restore hope to those people who are struggling. So these are really important things. This one's a buzz one. I bet you we'll get questions on this. CTE, chronic traumatic encephalopathy, right? So if you saw a Will Smith movie, right, about called Concussion, that's what this was about, that concussion causes it. As of right now, there is no definitive literature that says if you have a history of concussion that you're going to develop CTE. That's really important, right? Because that's what families come to ask me about. So how do we keep your kids active and get rid of these kinds of fears? So just as a quick little diagram, just so that we're clear, right? The brain and the cerebral spinal fluid, they all work together. Your brain's kind of floating in that. The injury of concussion itself is happening as your brain that's kind of floating in this water actually hits the inside of your own skull. right? So it's kind of like an intrinsic injury, right? So there's something of your own brain that's hitting the skull that's causing a problem. There's shearing forces that happen, twisting, and it changes the way that your brain works. So it's a functional disturbance. It's different for every person, right? I could see 5 concussions in a day and all 5 of them would look different. And there's a huge range of severity. And it can occur in practice. It can occur in any sport, fencing, cross country, you name it. It can fishing. It can occur anywhere. And it can happen in practice or competition. So many of you probably are familiar with what concussion symptoms are like. There's a huge variety. This slide groups them for you. So they can be somatic, so something that you feel. So I feel a headache, I feel nauseous, those are pretty common. One that's really common is the feeling brain fog. Brain fog's really, really common. Emotional symptoms, this one's really big. So sometimes, even if our athletic trainers or myself, if we know that kid or we know that person, and all of a sudden they're acting really ridiculous, like they're usually normally a pretty chill, even keeled kind of person, and all of a sudden they're blowing through the roof, that can be a sign that they've got a concussion. Certainly loss of consciousness and vomiting, that can be a sign. So there's a bunch of things, but I would say one that's pretty consistent is the person just not themselves. That's a really big one. Cognitive impairment is huge. A lot of times that's gonna come just when they get to school or to work if you're an adult, and then sleep, right? It works either way. You either sleep a lot or you can't sleep at all. If you're a visual person like I am, this is a visual shot for you. What does a concussion look like, right? So this is just a little picture, but a variety of different things. So this is probably one of my all-time favorite slides when I talk about concussion. It's this slide because concussion's a hot mess. There's a reason that a lot of people don't want to manage it because it's so difficult, because there can be so many different pieces of concussion that you have to figure out. Is it your vestibular system? Is it a headache? It's just headache. Is it my autonomic nervous system? Like my blood pressure is all messed up. Well, the answer is yes, like it's everything. And it's our job to figure out which one of those systems sort of went offline to be able to help you get back to your health. So it's messy, but like people like me kind of like it. So going back to this idea of the journal article that I was referencing, this was a really cool slide. It's wordy. I want to just highlight for you like the top, the things that are in black here. So this was a paper that was taking a ton of data and looking at how can we really reduce the incidence of concussion? Well, there's obvious things, right? Like being more strategic about how we play football. When are we allowing ice hockey kids to check? And for USA Soccer, there are changes that happen with heading, how early kids can head a ball. So thinking more about the sport gives you this idea of sport-specific prevention of when should we let somebody hit. So that was great because we have some evolving evidence that's very sport-specific, that by being smarter in the way that we play, we could reduce the incidence of concussion, right? The one that's highlighted here in the red was really exciting because of some of the new research that's coming out about concussion. So we know within the first 6 months after concussion, you're at more risk for getting another musculoskeletal injury. So the way that plans out is I get a concussion like this last week. I clear you, I get back, and then 6 months from now, let's say 6 months from now, you're kind of like in that transition of winter sports to fall sports, and I'm training and I plant and twist and I tear my ACL. So that's true. That comes from a really wonderful study that's actually from one of our researchers here in Colorado. This particular study looked at the fact that if we did participation, this was in rugby, in neuromuscular training about 3 times a week, that it was associated with a lower risk of concussion. What does that mean? If I look at how you move, I bet you I could figure out ways that you're moving potentially inefficient and places where maybe you couldn't get out in rugby, I couldn't get away from someone. So if we do training to sort of make you a better athlete and help you to be more efficient, maybe you can avoid some of those. That was really promising because that's something we can do something about. So remove, this is a big one. So there are a bunch of little slides in here on this. Your job, if you are not having the luxury of an athletic trainer or a sports medicine physician, a team physician, sideline, is like, how do you make that choice when you pull someone? More and more, there's a greater amount of pressure on referees and coaches and parents to try to make the right choice when there was potentially a concussion. And basically, the rule of thumb is if you're suspicious, I tell people, you get one brain, just one. We can put new ACLs in you. We could do that 2-3 times, right? The Olympic gymnast at one floor, she's had 3 ACLs, so okay, that's not great, but we don't get to get a brain replacement, so we have to protect your head. So When you need to remove them, the symptoms can be rapid in onset. They can come and they can go. One of my favorite stories from my fellowship was one of my wonderful colleagues, and he was angry. It was early in our fellowship. And he's like, oh, I want to do more. I'm just standing here holding this guy's helmet. And our fellowship director, in his shrewd way, came up and he knew he was irritated. He said, he can't play football if he doesn't have a helmet. And then the lights went on right. We're watching this guy. He can't go back out. We don't know if he's had a concussion or not. So we're watching, right? So things that are important in the setting of sports or wherever these concussions happen, you'll see them later, Maddox questions. Don't ask who the president of the United States is. Don't ask what season of the year it is. Ask them what field they're on, what mountain they're riding if it's a mountain bike, what race are they riding in. Ask them about stuff that's happening in the context of the concussion, because that's where you're really going to figure out if they don't know. If they say that, are we at home, are we away, and you're playing a home game, and they say, I'm playing in Fort Collins, you've got a problem. So those things are important. And then don't leave these athletes alone, because yes, a lot of the times it's concussion, but one of our jobs is to also figure out when it's not concussion. When is it a brain bleed? When is it something that's worse? So they are not trustworthy athletes, so they can't be left alone. And they won't remember anything you say anyway, so please don't leave them alone. So they cannot return to play that day unless they are seen by someone that is experienced in concussion management and they have been assessed. It's just too dangerous. So this is the thing that came out years ago from the CDC, and it still holds true. It's a great little saying. This would be one of those things, like I said, where you remember one thing. This is the thing. When in doubt, sit them out. And we'll come to it a little bit later, but there's state laws in every state in this country that will back you up if someone's angry at you for pulling a kid out of a game or pulling someone out of the competitive situation, because of the fact that worst case scenario, you can die. You can have something called second impact syndrome, and you can have sudden collapse. And if you take another hit while you're actively concussed, you can die. And that's why those laws across the whole country are there. So when in doubt, sit them out. That's what we call a PEARL. So removal of a player, other things that would be really bad. So if you're not sure and you're not medically trained, seizure, tonic posturing. So we would all kind of remember seeing some of these things on maybe Monday Night Football, where you saw someone posturing really strangely. They can't walk. They can't make a straight line. All those things they can't remember things. Pull them. They can't come out. There's the Maddox questions. Maddox questions are tried and true. They've been around for years. It's just asking questions that are relevant to the situation. Okay, this is a link. We're going to cross our fingers. This is a wonderful tool. So if you're a coach, if you're a parent, if you're a referee, you should have this, and you're not medically trained. You can have it if you're medically trained too. This is a tool that came out of our international consensus guideline. You can have it as a little pocket tool, and it's basically a little thing. So this will take you to the web page, and this is from the British Journal of Sports Medicine. And what you can see here is it's a little pocket tool that will give you a little fast way to figure things out. So we talk about this with our referees a lot. How can you make this decision? So please, please, please go get this. It's free for everyone. It is made for that reason. Nice little tool. So again, if you suspect a concussion, you need to get them to someone who can see them. It can be their family practice person who they're used to seeing all the time. That's great. They don't always have to come directly to me. Your family medicine docs and internal medicine and peds, they have a relationship with you. So they're going to know if you're acting kind of funny. But it's okay if you go to the ER or the urgent care. But please, please, please remember that the urgent care and the ER, they are there to make sure that you don't die. And so they are not the definitive managers of concussion. Concussion is an outpatient diagnosis. And so what that means is you don't get to go to the ER, get diagnosed with a concussion, then get cleared to go back to sport. That's not fair to put on the ER or the urgent care. So they need a follow-up, and that's really, really important. This one's really important too. Please don't have kids stay home until they're completely symptom-free. Maybe they might need a couple of days, or you as an adult might need a couple of days off of at work. But what happens is these kids get stuck at home in the dark doing antiquated, old school kind of ways of doing concussion. They end up depressed and anxious. So get them back to school as soon as they can, even if it's for a couple of periods. But we don't want them to sit at home. You want to find out what your school's policy is on concussion and get them back as soon as possible. Okay, I think that's most important. Here in this county, we'll talk about this briefly, things are a little different because we've been fortunate for over 10 years to have a really robust return to learn plan in BBSD, so we'll talk about that. This is not something that you need to know, it's a resource again. So the SCAT has been around also for decades. It's called the Sideline Concussion Assessment Tool. It is not for anyone that is not medical, it's for us, medical. And this is what it looks like. They get updated, so you can see this is the SCAT 6, because it was the 6th symposium for International Consensus Statement. There's a kid version and an adult version. So your athletic trainers, this is what they're going to use on the sideline. And so again, this is how we standardize concussion evaluation in a very specific way. And it is what we call in science, it's a validated tool. It means that there's research behind it that says this is the tool to use. So when do you worry, okay? Prolonged loss of consciousness, the longer someone has loss of consciousness, the more worried I'm getting. The more I'm like, okay, maybe this is a brain bleed. Maybe there is something else going on. This one's big in my world, so let's take mountain biking, something here in Colorado that everyone can understand, or biking at all. When you fall off of your bike, you might get away with the kind of thing in Boulder, a fractured clavicle, right? That might have to get surgically repaired or not. You're going to have more than just a head injury. So if you have distracting injuries or anything other than just your head injury, you're maybe not going to be the most reliable patient. So like as we all start football here in a little bit with home games, you'll see us running out onto the field, and sometimes that kid has dislocated his shoulder, he's done something, or a female soccer player has gone down and maybe she twisted her ankle too, and there could be a head injury. They're not reliable because they've got something dislocated or something that's hurting elsewhere. So in trauma, it's a distracting injury. So that's important for you to know. Repetitive vomiting that doesn't stop, that's concerning. This is a buzzword, especially in the ER, worst headache of my life. That could be something bad. It also can be from concussion. And of course, if they're unresponsive, and then a rapid decline in consciousness. So again, my friend, right, that's sitting there holding the helmet, if we're watching that guy on the sideline and all of a sudden he slumps, you know we're going to be on that. And we're going to be seeing that he's changing in his consciousness and his awareness, and that's got to leave our field. And if they're difficult to arouse, so this whole thing about like, don't let them sleep, like, yes, you can let them sleep, and there's studies that say that they need to sleep, right? We're getting more evidence on that. But if you go to kind of like rub them and they won't wake up and they're really difficult to arouse, you're going to be taking them. So this is Wonderful Ash. Oh, wait, okay. This is Wonderful Ashley, and this happened at the World Championships in 2022. The backstory on this is, unfortunately, this team had another pretty significant injury years ago in Croatia, and she was just having a rough time here. And what you're going to see here is not necessarily, these are falls that are leading up to her main event that happened. This is where it's happened. Close your eyes if you don't like this stuff. So you see she hits her head right there. She's lying, I'm going to interpret this. So that's her mom, who's actually her coach, believe it or not. So she's lying on the ice, and she is not herself. She's not getting up on her own. Watch here again, close your eyes if you don't like this stuff. She whacks her head against the ice, and she goes maybe out. Please watch this part. If you've never seen what a concussion looks like, she actually did fine, by the way. She's wonderful and is still skating and doing great things. But this look that you're going to see right here, if you've never seen what concussion looks like, this is what, they're going to zoom in, that's concussion. She's not herself. That's Tim, her partner. He's trying to assess her. There's my colleagues going out onto the ice to get her. That's what concussion looks like. So it's pretty scary. Hers is dramatic, but if you've never seen it, that's what it looks like. So when you do a sideline assessment, the best practice is, if you're working on development of a sports medicine program in your school or any place, you're a club, you're running a club, and you're trying to figure out how to take your club to the next level, get an athletic trainer, or at least contract them out so that they can be there for your games, so they can be there to help. That's probably the safest and best practice that we can have. And then apply the rules of when in doubt, sit them out, ask those sport-specific questions, like I said, and understand those signs and symptoms. And I guess here, err on the side of caution, right? That's the best thing to do. And I've taken a lot of heat through the years. And if I'm wrong, I'm willing to take that risk. Okay, let's talk about this, brain rest. So yes, back in the day, 2001, it's all about the brain rest. Okay, things started to shift. And then around the time like 2009, 2013, we started to realize that maybe not the greatest thing. We're taking these active people, kids or adults, away from something that's really important to them. Now we're seeing an increase in anxiety and depression. And guess what? Those symptoms look very similar to concussion symptoms. So Dr. Letty out in Pennsylvania said, well, what happens if we put kids on treadmills? Like, we've got a lot of college athletes that get concussed. What's the worst thing that can happen? We give them a headache and they throw up? Maybe. Put them on the treadmill, start getting them active sooner, and we realize, oh, early activity can be helpful for concussion. So what I don't want you to take from this, because this is where it gets very nuanced. How do you handle concussion? I'll walk in the door sometimes after my athletic trainers come out, and I'll look into that room and I'll be like, yeah, that kid's out for like the next couple days because they're miserable. I'm not going to have someone that's clinically miserable get on a treadmill. So again, back to one of my favorite slides that I said earlier, every concussion is different. So there may be one kid that has to do like 4 or 5 days of rest because they just feel awful. But then someone may, in like a couple of days, 2 or 3 days, be like, yeah, I went for a walk. I got on my trainer. I did pretty okay. It's different. So it may be that you need both cognitive and physical rest, but you're going to have to work that out. And this is why concussion and practicing it and taking care of it is really an art form. If you can get them back to school in that first week of school, that's great. If you can't, that's okay too. But there's a difference, okay? This is important. Another one of those light bulb moments. There's a difference between return to play and return to learn. And that applies to us as adults when we go back to work, as well as a student. So return to learn, this is really important. So when they go back to school, if they tell you that they're exhausted at the end of the day, that means, like for me in the second follow-up visit that they do, they probably haven't taken much in the way of academic adjustments. If they are trying to push through, so I tell this story very frequently in the office. You can't push through a concussion. Concussion proves itself all the time. I've seen someone in the Chicago Marathon break their femur at mile 18 and still end up in my medical tent and go directly from the medical tent to get their femur fixed. You can't push through a concussion because your brain is in this state of fatigue, so it will always reveal itself. The other thing is you have to get formal clearance to go back to sport. That's just wait. And yes, it may require another doctor's appointment, but you do need that. And please, 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 please don't try to manage this on your own. Get help. One of the pieces of the new literature that comes out is the faster we see you and the faster you get in for medical help, guess what? The faster you're gonna get better. So there's not a reason to wait. Maybe like the first or second day if you feel terrible, you don't even want to get in a car, but other than that, get seen. And then ideally, all of your symptoms need to be completely resolved before we return you back to play. So this is a bunch of data as well, but this just kind of talks about like in the treatment, this is straight from our concussion international consensus statement. This is about, yes, you're going to do some cognitive rest, but some early exercise can be good. Now, am I going to have you pounding the trails out there and back on your bike again where you could fall? Heck no. Am I going to get you on a stationary bike and give you very specific exertion and say, okay, go this rate of your heart rate, go this way? That's what we're going to do. So it can be variable. Again, you could have someone start to exercise on day 2 after they got concussion, or even day 10. So again, it's individualized. That's important. So there's no tried and true rule because every concussion is so different. So let's briefly talk about return to learn and return to play. Return to learn was really cool. This is a point where I get excited because I get to live in Boulder. I'm so proud of the work that we've done here. Over 10 years, we have this wonderful school district that we've been able to do really pioneering work with. And for over 10 years, we've had a very robust return to learn program for all kids. So not just our varsity athletes, kindergarten all the way through high school. So when we talk about return to learn and then you look at return to learn in the rest of the world and the country, what we get to do here in Boulder is pretty unique. So return to learn, this was the first time in the international consensus statement that there was a discussion of return to learn. So if you read that part, it's great. It doesn't entirely apply if you are here in Boulder, even St. Vrain. So they don't necessarily have the same stuff that we have in BBSD, but very similar. So we've had this partnership with Boulder Valley School District for long decades. And really this concussion education that we've been doing, and this partnership has been incredible. We have a brain injury resource team here. Those are some of our health colleagues, but it's also teachers, it is principals, vice principals, school speech pathologists, you name it. We've had coaches and teachers that have been part of this. So it's something that I'm really proud of our school district and the people that I get to work with to create this policy. You may or may not know if this applies to you. This would be a picture you take of this slide. We're fortunate to have team physicians at all 6 of our Boulder High School or Boulder Valley High Schools with an athletic trainer that I oversee as a director of outreach. So if you didn't know that you had a team physician and an athletic trainer at your high school, well, there they are. So what we had to do to make this possible is and if you're interested in this, I can have further discussions with you about it, or bringing something like this to your school district. It is something that as a district we've been committed to bringing this program to other places completely free of charge, just educating because we want to make kids better. We realized we had to take medical language and translate it into academic language. And so teachers are amazing. I'm married to one, so I know. They know how to do this thing called differentiate, and they can take symptoms and we can tell them what symptoms they have, and then they know how to take those symptoms and help a kid learn. So we needed to help them to translate, and that's what this slide's getting at. These are terminologies that I, of course, had to learn. We talk about academic adjustments, not necessarily modifications, so adjustments that can be made. And guys, this applies to kindergartners, this applies to all the kids at CU. So this applies whatever educational level you're at. This is educational lingo. We talk about differentiation. So if a kid has migraines or a kid has dyslexia, teachers know how to do that. Teachers also understand something called a 504, which is something that we talk about a lot in our concussion team, that once you've reached a certain place, and let's say you got a concussion that brought out your eye dysfunction, then we make a 504 for you so that you can continue to thrive in your educational experience, but you can have the academic adjustments that you need to for what your needs are. And then a 504 is different than an IEP. IEP is a little bit different. It's an individual education plan. We don't work with those as much. Concussions usually 504s. Another link for you. This is a little form. We have a variety of resources that would take a whole nother hour to talk about. I want to show you this. This is a link directly to the BVSD website, and I want to show you how to navigate. If your kid gets a concussion, and even if your kid is not a BVSD kid, feel free to use this. You go right down here. We updated these forms. You click on this form. It's a 2-page form, and it shows you in the first part right here, if there's an athletic trainer that is present, they can describe what happened. So if you're playing club soccer and you want to take this form, take it. We want you to use it. Then the first step is you have to be seen by a healthcare provider to diagnose the concussion. The second step is you have to get returned to play. And you can see here that we talk about the stages. If you go down, what you'll see is the new international consensus guideline. We made note of the fact that there's these early stages of exercise that you can see down here that you can go through. So don't be surprised, teachers, if you're watching. It used to be that the athlete couldn't go back to return to play until they were completely cleared of all their academic adjustments. Don't be surprised if you have a kid that is still now on concussion protocol at school, but they're starting to exercise. They're exercising to get better faster, so they're technically working in their return to play, but they're just not at that level where they're after step 3, which is where the risk goes up. That's where they have to see someone like me. So if you want to use that form, that's why that slide's there. This is another form that we have that's called a teacher feedback form. We have a variety of different things to help them. This would be another one of those slides that I would take a picture of on your phone or just have available to you. These are academic options that we have for all students. So this is like a washboard, this goes for everybody. So if you're at college, you could take this. These are just suggestions. In our district, once you get put on concussion protocol, there's going to be an email that goes out to you as the parent, as well as all the teachers, reminding them of the different academic adjustments that you can make. But this is wonderful, great resource. Please use it. Additionally, when we talk about making academic adjustments and treatment, how do we then, if there are symptoms that are remaining that are not going well, what do we do for them? So if you have persistent headaches, make our vision changes. We might be doing vision therapy with you. We might be doing physical therapy with you. If you have pre-existing mood disorders, which is huge, depression, anxiety, ADHD, you might need to do some medication changes. So we take these symptoms that you get from concussion that could be so huge, and then we design your treatment around it. So see, everyone's different. So a lot of this then we had to translate into the schools so that they understood how we were going to get these better. And I learned a lot. So maybe this is why I like concussion so much. I love my job so much because it's all about team. There's like no I in team, right? Like it's not about me at all. It's about the team that I get to work with. I don't get anyone better concussion or not without the team that I have. This is an example of what our team looks like. You have an academic team and you have a medical team. It's huge getting these people back. And so I wanted you to see, not everyone has to have all this, but these are the resources that we have to help you to navigate through your concussion. This is a really important one. Why is it that once you've seen one concussion, you've seen one concussion? Because of this. And this is what makes concussion research so hard, is because you can't control a lot of the variables. So things that can make a difference and make your concussion last longer. So the longer you have symptoms, the longer your concussion is going to last. I want to bring this one out, like these over here in the second column, co and pre-morbidities. So pre-existing history of migraine, pre-existing history of headache, pre-existing anxiety, depression, ADHD, learning disability, sensory integration. These things for decades have been proven to make your concussion more difficult to manage. It doesn't mean it's going to be. You could be fine, but if you have those, just know that those things could get worse. So we'll have parents come in and they'll say, what's going on with this kid? He was fine, he was happy, and then all of a sudden the world is ending. That can be, maybe that kid had ADHD tendencies, but his sport was helping him. And so he was active, he was able to do things. And while he was in his sport, he wasn't anxious or depressed, but then he gets concussed and you take that away. And next thing you know, you see those symptoms rise. One thing that you'll find with me is I'm very particular about diagnosis, especially in this context of this diagnosis of concussion. So we don't medicate concussion symptoms. You treat the concussion, you don't treat the symptoms. That's really important. So all of these things that are on this slide are things that can, just as I'm building a picture, if you come into the office, it's a pretty lengthy exam, especially depending on the severity of your concussion. Our athletic trainers spend a lot of time with you getting a lot of this information because it's just so important, because I'm listening. I'm building a map in my head. I'm building a picture of your story of what this concussion might be. Helpful hints. So this is important, and it's true. And this is not necessarily because athletes are always trying to lie. That's not the case. They just may not recognize it. I can't tell you how many times I talk to somebody and they're like, I had 7 concussions. And then you go through each one. Did they really? Or were there ones that they missed? So just realize their narrative may be different than the actual truth. So missed previous concussions is a big one. Please get a concussion history. I think perhaps one of the most important questions through the years that I ask, did you return to your baseline? That's so important, and we've learned a lot over the last decade plus about why that's so important. Teammates and coaches, they may or may not be helpful. They may have seen it. They may not have seen it and be giving you a different story too. So interpret that kind of with a grain of salt. They could be super, super helpful, or maybe not so much. Previous head injuries, face injuries, or neck injuries, really important, because those could have also contained concussions in them that just weren't identified. Facial fractures, that's a big one. And then remember, there will always be fear. And my hope, genuinely, that I do with everyone, is to teach you so that you're not afraid of this diagnosis. The more you can be educated about this, the less fear you'll have, and the better you're going to interact, and then you're going to come in and we're going to be able to partner with you to get things better. So return to sport's really important. As I was saying, now with all the knowledge that we know over the last 20 plus years, you can start that return to sport, maybe by doing some initial exercise, but the reality is each step on that gradual return to play is still going to take about 24 hours. So you're not going to get concussed on Wednesday and be playing in the game on Friday night. That's just not going to happen. It's not good medicine. if you're really concussed, okay? And you have to get healthcare clearance after that step 3, where you're increasing your risk. We cannot sign you back into the field of play or any kind of risk if we think you're still concussed. That's just not okay. The international consensus statement said it takes usually unrestricted return to sport. Their data showed 19.8 days. Several years ago, I think this was pre-COVID, we did a internal assessment in Infinite Campus, which is how we can mark concussion in Boulder Valley School District. And it was like, I believe the initial time when we put them on concussion protocol and then we cleared them for full unrestricted sport was 28 to 30 days. So pretty similar. These links in through here, again, this is another link for you that just takes you to what that return to sport looks like. That is on our website. So I noticed something. If you Google concussion return to sport now, this is such new research that the old return to sport comes up. This is the correct one. And it has the early activity in it. So if you want to know what it looks like, this is the correct one that should be used for returning to sport. So again, just another research. The other one, the top journal one, that's the actual journal article. Persistent symptoms, as I know we're getting close to time here. So in general, if you're still struggling with concussion symptoms for more than 4 weeks, it's time to get in and see someone. If your primary care doctor, pediatrician, internal medicine doctor does not feel comfortable, that's a really appropriate time for them to refer out to people like me and my colleagues. Get extra help because the longer you sit at home trying to figure this out, the harder it's going to be. This is the recommendation for rehab that they have in the International Consensus Guideline. If you're having dizziness, neck pain, headache, and it's persisting for more than 10 days, get some physical therapy, get in to see somebody, get started so you don't get stuck. And again, symptoms beyond 4 weeks in kids and adolescents, you gotta get them in, because remember, in kids or anyone that's in school, it's getting harder and harder and harder for them to get back to school because they're losing more and more time. As they return to learn, they got to watch for those symptoms too. So this could be a whole nother lecture, and it is in itself, rehab from concussion. I wanted to just highlight a couple things for you. What do you do for concussion rehab? A lot. And this is potentially one of my other favorite things. This is where I get to get super creative, and we look at how all the systems work together. So we do rehab the musculoskeletal system. We do look at the eye system. How do your eyes move? We look at your vestibular system, which is where you are in space. Then the other cool thing is this other part that I was talking about. We work on exertion. So our team that I'm lucky enough to work with, they're masters in all of this. So we have to understand all of this. And I think that's another reason why I love this diagnosis in sports medicine, because it's such a unique diagnosis. Other than maybe bone health in sports medicine, this is the complete essential knowing the athlete head to toe, and knowing how you integrate all these symptoms is the key. And that's where the art is. This is a smattering of just a little bit of some of the active things that you'll see us doing in concussion. On the bottom, you'll see our flume. Get me talking about the flume, I'll talk forever. This is a pool that we have over there that we can set a current on. And I did a whole separate lecture on extreme sports medicine and how we take sport-specific concussion and bring it back. And the flume and the water have been incredible for us. Post-concussion syndrome, I just need to emphasize this. This is a thing. Maybe this is just my pet peeve, but I think I'm sensitive for patients. Post-concussion syndrome carries a stigma. And if you're walking around with post-concussion syndrome, I think that it weighs heavy on you. So please know that you're not going to go to the ER or the urgent care and come away with post-concussion syndrome. If that concussion happened just recently, you're concussed. You're actively concussed. All post-concussion syndrome means is that your symptoms didn't resolve in a given amount of time. And when that happens, and you obviously need to see someone. Also, people feel hopeless when they have the diagnosis of post-concussion syndrome. And guess what? There's this beautiful thing called neuroplasticity and this wonderful thing in our body that we get to rehab. And so just because your concussion happened however many months, years ago, we can find these things and get you better. So I'm very particular about the use of this word because I'm sensitive to what patients' experiences are when they have this diagnosis. So again, you leave with the concussion from the urgent care or the ER. You're not post-concussion syndrome. You're concussed. You're actively concussed. And remember, here's the good news. Most concussions are still going to get better on their own. Yay! And you don't ever have to meet me. Isn't that great? Thanks. So the last thing, this is what I mentioned, is second impact syndrome. Just so you know, it's pretty rare. We think it's probably not documented very well, but it doesn't matter. This is why there's laws in every state. This is the idea that they're concussed, they go back out, they get hit again, and we don't really understand why. It's rapid collapse of your neurologic system, and this is how people die. So if you want to know why no symptomatic athlete can return to play, this is why. So where do we go from here? We're really excited. We have this wonderful partnership also with BCH and working with the trauma team. We do a lot of work in the community to try to centralize concussion care. We had revamping that had to go on after COVID, but we're still very much alive and in the community and working to bring education to you, like in forums like this. So the more people we touch with education, the better this is going to continue to go. Last couple of things I want to tell you that's really exciting. In the last part of the paper, this was one of the first papers that ever talked about our para-athletes. Our Paralympians with different disabilities. There's a call for more and more research there, as well as with children. This idea that we need a whole different way that we're approaching our para-athletes is really important, and that was mentioned. And just like the return to learn, this is a step in the right direction of identifying these people. So it's incredible. This is really incredible work. So what have we learned? Kids graduate and kids change, or teachers change jobs. So we constantly have a job of teaching you about concussion. Sorry, guess we're never going away. And kids and teachers have to talk. I can sit in my office in Folsom Field forever, but if your kid doesn't talk to your teacher about what they need, it's never going to happen. So you got to facilitate that conversation. The bridging also between school nurses and health room paras and school athletic trainers is essential. We've learned that. We've learned a lot of tips on how to do that. Coaches need education as well. We just finished our coaching education here in the district, and they're going through it right now. Speaking the same language is essential. I learned a lot from our educators through the years, and I had to learn how to speak that way. This one we've learned too. Concussion doesn't matter till it matters. So I don't know how many of you are watching tonight that have had concussion, or you're like in a position where you're seeing concussion, but we've tried to give concussion lectures, and it doesn't matter to people until they've experienced it, usually. And then again, once you've seen one concussion, you've seen one concussion. And then the thing that's really awesome is concussion programs do work. So this man is a really inspirational. Whether you like Disney or not, it's okay if you don't like Disney, I still like you. But I love this quote from him. He said, it's kind of fun to do the impossible. I feel like that's what we've done in Boulder with concussion, and it's been wonderful, and I look forward to continued wonderful work. And this is just a short shout out to just all the people for over a decade that has made this work that I do possible, that I get to be the voice of, but it's really not me. I couldn't have done it without all these wonderful people. Okay, I'm ready.
Thank you so much,
Yeah.
Dr. Ballantine. It's always so informational. We really appreciate that.
Sure.
We have some questions from
Great.
our audience. We do
Wonderful.
want to remind our audience that now is the time for questions. Put your questions in the chat box, and we will get to as many as we can tonight. And in no particular order, we're going to start going through these. Will there be another international conference in 2026?
Great question. Yeah, there will be. And so I don't know when it's officially going to be. As I said, this one got delayed. I actually am lucky enough to now be a part of that work group. And so I don't know when that's going to be, but they are definitely expanding that group, and it will continue. This work will continue. That's a great question. So yes, there will always be more.
Is there any imaging that will show a sports-related concussion, such as an fMRI?
Functional MRI, you're very smart, whoever's asking that question. Functional MRI and PET scans are some of the research-based clinical tools. No, it's not really, they're not clinical tools. They're research tools that can show this. So when you see beautiful pictures of brains that look like works of art, that's what they're talking about. Those are not ready for us to use. So they are being used in research, but they're not ready for us to use clinically. It's an excellent question, though.
Okay.
They're really expensive.
I'm sure that plays into
Yeah.
it. As an adult, where can I get medical help for PCS other than a neurologist with an 8-month waiting list? My PCP referred me to a neurologist with a very long wait list, and that was the only suggestion.
It's so hard. First of all, I feel for you. I think one of the biggest things that we as the group have really tried to do, at least in this county, but you see this is a problem nationally. People with concussion get lost. They get lost in the system. So depending on how your concussion happened, bike accident or, playing football with your kiddo or whatever, certainly if it's sports related, that's our area. If you're an athletic person, that's for us to deal with. You're right, it's really tough. Like neurology sees concussion. PM&R doctors, you may not know what those are. Those are physical medicine and rehab doctors. They will see concussion too. It's gotten worse, I think, after COVID with just waits. Sometimes what you can do while you're waiting to be seen is if you can talk to your primary care physician and at least get in some sort of physical therapy, that can be helpful. But what you're saying is absolutely true. And it breaks my heart because folks such as yourself get lost in the medical system, and that's what makes the experience so much more harrowing. So I don't have a great answer for that, but if it is something that is, if you're a really active person, a lot of times what we'll do too, or what I will do is I'll do a phone call with you first and say, hey, are you for me? Are you the kind of patient that I'm good at rehabbing, or do I need to direct you someplace else? So that's always an appropriate way to go too, because I don't want to waste someone's time and bring them in if they're not really appropriate for me. So that can be an option. So yeah, that's tough though. I'm sorry.
So as a sports medical professional, which you are exactly the same as a neurologist?
Oh, that's a great question.
Or is that
wonderful
different
question
that you can go to
right.
someone like
Thank you? Thank you for that. So so neurology has seen concussion for years, but neurology actually just started, I believe, within the last decade. They have now developed their own fellowship. It's called sports neurology, because the sports medicine doctors have been doing concussion for decades and decades. And in talking to neurologists, depending on what they're like, you'll meet different neurologists like, I can't do all this. I can't see stroke and Parkinson's and all the stuff that I see, and then also see all these sports concussions as well. So that's an excellent point that she makes. There are neurologists, they're not very plentiful, that have done neurology as their primary job, and then they've done a fellowship in sports neurology. And so a sports neurology fellowship is like it's heavy on just the neurological issues in sports medicine. But they're not going to manage your fracture. Like a day for me in the office will be multiple concussions, maybe an ankle fracture, a pulled hamstring. So my job as a primary care sports medicine doctor is understanding the active person from head to toe. So it's a great question. So a lot of times you'll see there's very different management styles between sports medicine and neurology. I will tell you, if you see 10 different doctors that manage concussion, all 10 of us are going to have a different way to do it. As long as we get you better, that's the most important. But that's an excellent question. And not many people know the difference. Sometimes people think all I do is just see concussion, and they're shocked when I can take care of their hamstring, their knee, their broken toe, whatever.
Okay.
Yeah. Great question.
As a vascular illness, how did COVID impact incidence of concussions? And was there perhaps more damage done by COVID to the brain than was made about that, and makes you prone to concussion after being ill?
This person is asking a very smart question. So in COVID, one of our colleagues that we work at, she's been wonderful for the state of Colorado, Karen McAvoy. She's an educational psychologist. If you go on Google, for the people that are interested in this, go on Google and type in COVID and type in concussion. And you're going to see Karen's wonderful Venn diagram, literally a Venn diagram that will come up. We'll have your two circles and all of the symptoms that are similar and have overlap. So what's been really interesting is now our patients who present to me in the office that say, I think I have long COVID, but I also have concussion as well. How does this work? There's a tremendous overlap. And it's really interesting. Another fun fact, if you want to have fun on Google tonight, Dr. Google gradual return to play for COVID. It'll look strangely familiar to gradual return to play for concussion. So they took a lot of things from COVID and applied it, from concussion and applied it to COVID. So there's a big overlap. So you're very much correct. There is a lot of overlap between the two, and it can be really nuanced trying to figure out what's concussion and what's COVID. It's another art, and it's going to continue to evolve, but that's a great question.
Okay. This person had their first concussion over the course of the year. They then got hit in the head and would feel concussion symptoms regardless of how hard they were hit.
Yeah.
Were each of these considered a new concussion? And then now it's been a year, they have PCS, and then if they get bumped in the head, is that, again, an additional concussion because they feel symptoms?
That's what's so fun about this format of being able to answer your questions like this, because there's so many different directions I can go with this discussion. Those are called subconcussive threshold or subconcussive threshold hits, if you want to say. There's a lot of research that looks at that. What I can tell you is this: you probably, again, without seeing you, but you probably did have that one concussion, and you probably didn't really get back to your true baseline. And so there's this idea in concussion management called the threshold concept, that's once you've sustained one concussion, you're more likely to sustain another. What our research in the center tells us over the last 10 years is that maybe one of the reasons why that exists is because you don't really get back to your baseline. And if you remember, I said that multiple times, getting back to your true baseline is extremely important to us. So if you come back at 85% and then you get another concussive blow, it may not be as much of a concussive blow as it took the first time for you to feel like you had concussion symptoms, but you'll get a little hit and now you feel concussed again. This is extremely important and something we pay attention to. So that's a great question, and it's real, and it's probably that you had the initial concussion, you didn't get all the way better, your systems aren't all the way back online, and you get little hits and it's exacerbating those things that aren't better.
This person has lingering symptoms. It's been going on 8+ months. They have PT, they have massage, they have acupuncture, cranial sacral therapy. What can you do? Can you help?
This is another, these questions are just awesome. So this is the look that the athletic trainers come out like, Sherrie, we don't know what you're going to do with this one. They're already doing this, and this. There's a lot of good answers for this. And I guess one thing I would say is, do you have a quarterback, right? So do you have someone that really is looking at you holistically, or are these therapies that you're trying to find on your own? Is no one directing them? One of the things that you'll find with patients who have concussion is they sort of have to, like that one person that asked about like, where do I go to get help? You'll find patients get lost in the medical system and then they have to direct themselves. I cannot tell you how many patients I see that are doing exactly what you're saying, but what you don't hear is a narrative. Who's driving the bus? Who's helping you to make these decisions? These patients become like professional patients and their full-time job is going to all these treatments, but what you don't hear is a quarterback. So that would be one of the things that I would say is, do you have a quarterback that's guiding you, or are you self-directing this care? And then the other thing that we've learned over the years is that's why like a center is really good, and the way we've worked really hard to streamline our care. Sometimes a lot of patients have really stagnated care, and you have one person doing eyes, one person doing vestibular, one person doing this. And to get someone better from concussion, you have to merge all of them together. And so the right hand doesn't know it's talking to the left hand, and that can stagnate your care. It's hard.
We're close to the end of our time, but we have 3 or 4 more questions, so we're going to blast through those.
Great.
Should you give someone with a concussion medication such as Tylenol or Motrin? This person has heard it could prolong the symptoms.
Excellent. Thank you. I should, you know what, thank you. I'm going to change my lecture because of that. I'm going to add that in the myths now. That's a good one I should add now. You can use it. It's the old school thought was, right, let them sleep. Don't let them sleep, and don't give them ibuprofen because if they have a brain bleed, it's going to make it worse. You can give them ibuprofen. You can give them Tylenol. However, if they are needing that a lot, then what's happening is that you're treating the symptom and you're not treating the concussion. So if they're reliant on that, that's not a good thing. They need to be seen to figure out why they're getting the headaches is very important. And then you can also get rebound headaches. If you continue to take anti-inflammatories for a long time, when you stop them, you can get a rebound headache.
Okay. Can you elaborate on how neuroplasticity helps heal post-concussion?
I mean, I would love to. It's what I do. It's the art. One of my all-time favorite patients, amazing guy, typical Boulder adult, super active, doing a lot of things. And if you were to talk to him today, he would tell you when we first met our team, he felt like his life was over. He was depressed. He felt like he was losing his identity. Over time, what we realized is that he got stuck in that post-concussion kind of slump, and he couldn't walk, he couldn't climb up a ladder, and we realized that his eyes didn't work right, his vestibular system was off, but his neck was terrible. His neck was awful. And so even though it had been a long time for him, and he really was like a last hope, his primary care doctor sent him to me, excuse me, and even after all those years, when you get the right diagnosis and you start to retrain the brain, it's like a beautiful thing. And he's doing great now, and he rides a bike and he swims and he does all these wonderful things. So human body is an amazing, artful thing. And just like a fracture, my job to heal a fracture for you is to put your bones together in a way that your body does all the healing. So correct diagnosis then allows us to retrain your brain and grow new pathways and make those pathways happen again. And that's awesome.
Cool. What are some active sports communities that are underserved?
Oh, I love this question. I don't know that I've ever gotten this one. That is a wonderful question. I'll tell you who's underserved. Decentralized sports. And what do I mean by decentralized sports? So I'll take it from the Team USA level. So I work with US Figure Skating. We're a decentralized sport. Cycling is a decentralized sport. So there are places like football is not really a decentralized sport. There are hubs, right? And training places and teams. So if you are part of a decentralized sport where you're sort of off doing your own thing and there's not like a central place, that's a hard place. Like some of your off-brand, less common sports are underserved. So I'll pick a patient population that I work with a lot. So dance is extremely underserved. Performing arts is underserved. So if you don't have a varsity system and you're not working in a varsity system, if you don't have an athletic trainer, if you don't have a team physician, those are places where people are underserved. And I'm so thankful that you asked that question, because we got to get to those people. In my sport in particular, in a lot of these places, we're just doing basic concussion education. You know, don't be afraid of concussion. There's things we can do to help you. That's a really, really important question. Thank you for asking that.
Okay. Last question.
Yeah.
If you've had a concussion and have recovered, is there any data on long-term impacts, such as when you age, because you had a concussion?
Wonderful question again. I sat through a 2 or 3 hour seminar on this. That was a representation at the American College of Sports Medicine of 20 years of data from the NFL. And this, I'll focus on this data because it's really new and you probably haven't heard it. This is why the work we're doing tonight is so important. So just because you've had a concussion doesn't mean you're at increased risk for Parkinson's or movement disorders or Alzheimer's or things like that. The pathway to get to neurodegenerative diseases is complex and has multiple reasons. So what was really interesting about the data that the NFL has presented, and you can decide for yourself whether or not, in your opinion, it is biased data, but I can tell you, I know the people who sat and presented this at our college, it was outstanding. So what they did, it was probably one of my favorite lectures of the year that I've heard so far. They took data, 20 years of data, and they looked and age matched these guys that are playing in the 80s and the 90s, et cetera, before we had this huge paradigm shift. And they looked at the incidence of age incidence. So normal 60 or 70-year-old guy, what would a normal population have as far as incidence of anxiety, depression, Parkinson's, movement disorders, those kinds of things, and there was no difference until you got to 9 or more concussions. And that's a bigger discussion because how were those concussions defined? So as of right now, this is a really active part of research, but just because you've had a concussion doesn't mean that you're going to end up with a really bad disease later in your life. I would argue that stopping being active is going to have higher risk for you as a person, and stopping being athletic because you're afraid of concussion than getting one concussion or a couple concussions and then developing a neurodegenerative process. In my world of sports medicine, exercise is medicine. So my job is to teach you how to navigate this and still stay active and healthy.
Thank you so much, Dr. Ballantine.
Thank you. Thanks so much, everyone.
Great.
Really appreciate it.
We've come to the end of our time. We want to remind our audience that if you have additional questions about concussion, they can be emailed to pr@bch.org. There's also a recording of tonight's lecture. It's available at bch.org/livestream, and you will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us, and have a good night.